इसमें ये पीपीटी कैसे ये वाले प्रेजेंटेशन उस पर
चलो चलो
कितने लोगों ने लॉगिन किया अभी पता लगेगा? सिद्धार्थ
स्टार्ट कर लेते, आप पहले कर लेना।
हाँ सर, सर्जिकल पार्ट्स का
फिर मैं करूँगा या रंजित कर लेंगे।
श्योर।
लोड कर रहा है, लोड हो गया ना?
हाँ सर, मेरा लोड हो गया।
ठीक है सब।
हाँ, I was
बनाना पड़ेगा, बोल रहे गूगल मीट्स वो तो पहले बात करना पड़ेगा। आप शुरू करें।
So class, welcome to the seminar covering topics of uromalignancy. We'll cover this thing under three headings: the surgical aspects, surgical clinical aspects, the medical oncology aspects, and the radiation oncology aspect. And we'll try to brief you regarding the various aspects through inputs of various specialties and how the field of uromalignancy has evolved over the duration. So when we say uromalignancy, we basically mean malignancy of origin of kidney, ureter, bladder, prostate, urethra, and testicular tumors. The part that we'll be covering today in detail will be renal bladder malignancies and testicular tumors. I'm Dr. Siddharth Jain, Assistant Professor Urology. I'll be presenting slides of Professor Amlesh Seth. So this is the outline of urological malignancies: renal origin, urothelial, that is bladder or upper urothelial tract origin; prostatic malignancies; testicular, penile, scrotal or urethral malignancies. We'll start from the top: renal malignancies. So on the offset or on the start of the topic of renal malignancies, as a clinician I would like to highlight two basic points. Number one, the amount of renal malignancies now presenting in OPD because of detection on an ultrasound or a radiograph has increased dramatically to up to 70% of the total load, while the clinical presentation has now reduced to less than 30%. Now when we talk of radiological presentations, we mean that we are dealing with solid or cystic renal masses, nothing to do with benign, malignant or various subtypes of it. So a large part of our discussion will be regarding solid or cystic renal masses. Now there are two specific features of renal malignancies that are different from other malignancies. Number one, the role of CT and MRI in differentiating various subpathologies is very limited. Despite so many advances, despite so many protocols, despite so many additional nuclear medicine imaging and other things, we still do not have substantial evidence that these signs belongs to some set of these malignancies. This is number one. And number two, the role of biopsy. Core needle biopsy, as in other tumors, here has very limited role. Thus, to differentiate benign and malignant pathologies, as the classification I am showing is here, is predominantly post dissection or as a detailed histopathology examination with immunohistochemical markers. So this was to start with, that we deal with 70% of radiologically discovered renal tumors, and these tumors are rather solid and cystic rather than benign and malignant. So now let's begin from some basics. The renal tumors can be of benign or malignant origin. Benign can vary from adenoma to oncocytomas to angiomyolipomas, and rare variants like leiomyomas, lipomas, hemangiomas and other GG cell tumors. While malignant tumors, we have two predominant categories: renal cell and urothelial. In first part, I'll discuss renal cell. Renal cell, and like renal cell, Wilms, sarcomas and secondaries are other malignant tumors. So now, as I told you, adenoma, oncocytoma, there is no definitive clinical or radiological feature to differentiate them from any malignant tumors, and predominantly they only after a detailed histopathological supplemented with immunohistochemistry that we come to know that these are benign adenomas. Oncocytoma, just recollect your information from classes of pathology. These are of pathological interest. Around 3% of renal tumors are oncocytomas. They are very difficult to differentiate on radiology or on needle biopsy. They are classically classified on histopathology post resection. The main feature is spoke wheel appearance and intensely eosinophilic cells. Angiomyolipoma, this is a special category of benign renal tumors. It has three elements: angio, myo and lipoma. Because of these three elements, there is some the role of CT and radiology to pick up all these three elements and to suggest that we are dealing with this kind of benign tumor. So this is one exception of common renal tumors, and this is pretty common. It's a benign entity containing all three elements, as I told you, and on CT we can differentiate the fat element of it. Usually they are asymptomatic and don't seem to cause much problem except they are detected on ultrasounds, but if they grow larger than 4 cm or in females multiple or in pregnancy state of pregnancy, they may pose life-threatening complication of intrarenal or intrarenal bleeds. Most important of this category is renal cell carcinoma. About 3% of all cancers and 85% of all renal tumors are renal cell carcinomas. We usually encounter them in 5th to 6th decade of life, more common in male, and has etiological attribution to cigarette smoking, asbestos exposures, VHL disease, hereditary papillary RCCs, and such kind of genetic variants. Now these are to rush up through your pathological understanding of RCC, that there are subvariants. There are even more subvariants that are added each day with newer classifications. Predominantly it's clear cell, and second most common variant is papillary, and the others you can remember are chromophobe and collecting duct type. Classification system has evolved from days of Robson's classifications. This is just a basic about when it's situated within kidney. Stage 1, stage 2 is Girota, stage 3. Now the most important sub feature of RCCs, they have tendency of migrating in vessels, that is IVC involvement. So this is a very peculiar, and very few tumors show this condition, that of IVC migration and involvement. Lymph node involvement is pretty rare, but if seen it's stage 3B, and adjacent organ becomes stage 4. Clinical symptoms, as I told you, now we see 70% of these tumor as asymptomatic, detected by radiologist on ultrasound or incidental CT scans that are done for other conditions, and the rest 30% may present with classical triad of internist tumor, which is lump, flank pain, hematuria. Now this is again a classical triad, not anymore seen classically, it's rarely seen now. And the term I used was internist tumor. That is because in earlier understanding, RCC may present with whole variation of medical symptoms. That is why it is termed as internist tumor. So right from all paraneoplastic fever to all paraneoplastic symptoms may be associated with renal cell cancers. RCC's number one, its affinity to migrate in IVC, and second is presence of paraneoplastic symptoms. Now paraneoplastic symptoms like anemia, erythrocytosis, hypercalcemia, hypertension, and a special category where liver dysfunction is involved is called Stauffer syndrome. Each and every one is a classical definition, more of pathological background. Now to move ahead with investigation, I would say that as a clinician, when you sit in OPD and see cases with such findings, so whether it's a solid or a cystic renal mass, then you proceed with certain investigation that may help you supplement the data, which includes complete counts, blood counts, kidney function tests, definitely to know whether we are dealing background CKD patients, X-rays, definitely. The most important investigation is contrast enhanced CT scan. That is also a special protocol termed as a renal protocol. Now what is a renal protocol CT scan? A renal protocol CT scan compares a NCCT, corticomedullary phase, and early excretory phase. These three phases, when compared to each other, will give a complete information that is required to make a diagnosis of a renal mass suspicious of being renal cell carcinoma. MRI has role in diagnosis of venous thrombus, and angiography and other investigations may be required when we are dealing with locally advanced tumor. Now this is one tumor where I can safely say that whether it's a stage 1, it's the answer is surgery, whether it's stage 2 answer is surgeries, whether it's stage 3 answer is surgery, and whether it's a stage 4 or metastatic tumor, then also the first answer is surgery. So for all stages here, the first option remains radical surgery. There have been advances in field of medical oncology, and there are now evidences about use of TKI therapies as well as immunotherapy, and both of these therapy in neoadjuvant as well as adjuvant settings have helped us improve the outcome of stage 3 and stage 4 advanced renal cancers. Being clinician, I'll just take you through some interesting photographs. Here is here you can see the renal vessels and a pole of the kidney being involved after mobilization of renal vessels being clamped, and the tumor being resected out of the upper pole of the kidney, and this particular procedure is termed as partial nephrectomy, whereby we were able to save majority of parenchyma, just removing the tumor part. Immunotherapy and radiotherapy will be covered subsequently and in much more details. I'll skip to the second most important of the tumors, which is urothelial tumor. Now I told you that renal tumors kidney also have collecting system, pelvic pallidal system, which is lined by urothelium, and it is classified under upper tract urothelium, pelvis and ureter, while lower tract urothelium covers bladder cancers. The of all urological malignancies, the one that is showing most rapid increase is urothelial tumors. These urothelial tumors have been classically classified as transitional cell or urothelial origin. More than 90% of bladder cancers are transitional cell cancers. 5% may be squamous variant, squamous cell variant. Lesser are adeno. Now undifferentiated, mixed and rare variants of carcinoid and melanoma also exist. Bladder cancer, coming to bladder cancer, it's one of the most important cancer that is showing a rising trend. Encountered in male 3 times more than females in their 50s and beyond, and it's extremely strong association with cigarette smoking and chemical exposure like dye, rubber industries, petroleum, printing, benzidine and other cyclophosphamide like chemotherapies. So it has a strong association with chemicals exposure. Again, the pathological part of it, as clinician, what is important to us is to know whether we are dealing with superficial bladder cancers or urothelial tumor or a muscle invasive urothelial tumor. Superficial urothelial tumor can be saved with the organ preservation approach and use of endoscopic surgical method together with intravesical immuno and chemotherapy, while a muscle invasive variant usually requires more aggressive radical surgery in form of radical cystectomy with lymph node dissection and supplemented with chemotherapy and maybe with radiation. So carcinoma in C2, TA and T1 stages are classified as superficial, and they may be of low grade or high grade. Grade can be classified as low grade or high grade, and muscle invasive tumors are usually T2 and beyond. Classical presentation of bladder cancer is hematuria. Hematuria with features like gross, total, painless are extremely classical. Gross, total, painless hematuria. Patient presenting with gross, total, painless hematuria is extremely classic of bladder tumor. They may also present with passage of vermiform clots and intermittent colic, and these are also feature of upper tract urothelial tumor originating in renal pelvis or renal ureter. If not hematuria, then lower urinary tract symptoms like frequency, urgency and dysuria may also be associated with early symptoms of bladder cancer. If advanced, then it will present with complications of metastasis, renal failure due to obstruction of urinary flow. When a patient walks in OPD with complaint of hematuria, especially if he is a male in his 50s and with exposure of tobacco and smoking, the suspicion remains urothelial cancer. So whenever encountering a urothelial cancer, we need certain investigations to confirm our diagnosis, and then we need some supportive investigations. So how do you confirm a diagnosis of urothelial cancer? The investigation of choice to confirm this thing is urinary cytology together with ultrasound or contrast enhanced CT scan. These two investigations will tell us whether we are dealing with urothelial tumors or not. Supplemental investigations of renal function, complete blood counts, and urinary microscopic evidence of microscopic hematuria supplements the primary imaging modalities. Now, once you find out that you are dealing with urothelial tumors, the next stage is to confirm. Here comes the role of biopsy. The biopsy in bladder cancer is taken transurethral, which is endoscopically, and the term we use is transurethral resection of bladder tumors. On the basis of transurethral resection of bladder tumor, we'll find out the stage of the tumor, whether we are dealing with the carcinoma in situ, superficial varicose variants, which are TA, T1 when only lamina propria is invaded, T2 when muscle is involved, T3 is when reaching up to surface and beyond. So all these stages can be classified after transurethral resection of bladder tumor and pathological examination. As I told you, for clinical management, we need to see whether we are dealing with superficial tumors or invasive tumors. Superficial tumors require additional therapies in form of intravesical BCG, mitomycin, and repeated cystoscopic follow-ups, re-resection if there is any recurrence. While if we are dealing with more invasive variants of tumor, then the answer remains radical cystectomy. Radical, as the term suggests, radical means removal of urinary bladder together with all its surrounding fat, lymph node dissection up to the bifurcation of the common iliac vessel, and supplementing it with urinary diversion either in form of a neobladder or a ileal conduit. To supplement it with adjuvant chemotherapy or radiotherapy has its own indication and will be covered subsequently. Image of neobladder reconstructions. Now, there has been an evolution in the protocols that we follow for muscle invasive as well. Some younger patients and a limited amount of disease can be offered bladder preservation protocol, which involves limited resection and extensive use of chemo radiations. I told you the most common variants are transitional cell variant. The second most is the squamous cell. The third most common is the adenocarcinoma. Now this is a spatial variant. You usually don't encounter adeno in bladder urothelium, but more in intestinal variant. But there are conditions like exostrophy of bladder or patent urachus. These tumors tend to originate through these routes. Prognosis is worse than the earlier variants, and the treatment requires aggressive radical cystectomy and chemotherapy. Squamous cell, this particular subset is on a decline. Earlier seen in patients who were maintained on extremely long duration catheters, had negligent or bladder stones, or in Egyptian areas where parasitic disease were known. Less seen in our scenario where smoking is the major cause of bladder cancer. Treatment remains radical cystoprostatectomies. Upper tracts. Now, field change is something that the term that you have encountered in oro head and neck malignancies, pharyngeal malignancies. Field change phenomena stands in upper tract or urothelial malignancies of bladder also. So field change means that we encounter malignant dysplastic changes not at just the point where we see malignancy, but in other surrounding areas as well. That is primary cause of recurrence. Now field changes there, as I told you, upper tracts also have urothelium. They are less common than bladder, but the risk factors are similar to bladder cancers. Upper tracts also present with hematuria. They may present with kidneys, renal lump in form of renal swelling, and intermittent passage of vermiform clots with pain. Investigation protocol remains similar, and treatment option remains nephroidectomy with cuff of bladder. a lot of chemotherapy and radiation protocols exist in management of advanced form of urothelial tumor. That part will be subsequently covered. My role will be to take you through clinical and surgical aspects of it. The third most important cancer that I would like to discuss with you people is tumor of penile origin or penile tumor, penile malignancies. Now, penile tumors are, as a clinician, you need to rule out the benign lesions, pre-malignant lesion, and to reach up to a malignant lesion. So, penile cancer is something. Penile lesions are something that may be classified as benign, pre-malignant, or malignant lesions. The special pre-malignant lesion that requires special emphasis is leukoplakia. Leukoplakia or the whitish patch. The increasing pre-malignant potencies of melanitis xerotica obliterans and condyloma, the lesion of viral origin like condyloma acuminata, Kaposi sarcoma, bovinoid papillosis. So these all have malignant conversion potential. So these are termed as pre-malignant lesions in carcinoma of penis. Now the locally advanced or invasive, locally invasive tumors include varicose variants of penis such as Bushkill-Lowenstein tumor, and the treatment here involves excision with safe margin. By cancer of penis, I mean squamous cell carcinoma of penis, the most common variant of it. It may be of carcinoma in situ or invasive variants. The CIS variant has also been the subtype of which is erythroplasia of Kirat or Bowen's disease, can be proven by taking biopsy. And if proven as carcinoma in situ, then the treatment remains as local excision or use of 5-fluorouracil or cryotherapy using lasers. So penile preservation techniques can be applied. While when we deal with invasive variants of these tumor, then we need an aggressive management strategy. Smegma is carcinogenic. There are indirect evidence to it, as Muslim and Jewish population have lower risk compared to non-circumcised population. Yes, virus has a role to play, as HPV is proven to be a causative factor in both cervical tumors as well as penile tumors. Now, when a patient present with a lesion of penis which is suspicious to be malignant, then these lesions may appear to you as papillary, ulcerative, proliferative, ulceroproliferative, secondarily infected, or tight phimotic, which is not visible from outside but only after circumcision, or small lesions which with inguinal lymph nodes, or just with bleeding. All these may be clinical presentation of CA penis. CA penis by diagnosis and presentation is on decline in Western population, but we still have a large burden of this tumor. This tumor is extremely aggressive. Even after surgery, for stage to stage, the prognosis is poor, and dramatic presentations in emergency with femoral blowout still remains a surgical nightmare. Now, when a patient presents with a renal the penile lesion which is suspicious of malignancy and appears to you, and as I explained you earlier, the next line is biopsy. Biopsy from edge or a wedge biopsy is the biopsy of choice in these patients, where we can take a wedge involving both the malignant or suspicious part and normal tissue, and the pathologist can then help us find out the type and the depth of invasion. The other supportive investigations that are required are CT of pelvis for lymph nodes, chest x-rays for metastasis, and other kind of. Now here you can see limited penile lesion of suspicious origin. and biopsy will confirm us whether we are dealing with carcinoma in situ or any invasive variant. Depending on the variant, and the treatment remains as if it's only involved the prepuce, then circumcision may be adequate. If it's in the glans, distal shaft, then the treatment of choice for local management is partial penectomy. Partial penectomy with approximately 2 centimeter of normal tissue margin. If it involves shaft as well, then one may resort to total penectomy or radical penectomy. Management of lymph node in itself is a topic of great discussion among urologists, and aggressive approach is usually kept for managing lymph nodes in invasive variants of penile cancers. So if there is a palpable node in obviously T2 or beyond lesion, then the palpable site is given a radical ilioinguinal lymph node dissection, while the contralateral side is given a superficial or a modified for lymph node staging or biopsy. So when I say radical ilioinguinal, that means that the lymph node packets along the femoral inguinal region and deep pelvic and the iliac region together with pelvic lymph node needs to be dissected. In case disease is extensive or lymph node involvement is extensive, there comes the role of chemotherapy and palliative radiotherapies. Testicular tumor. Now, in testicular tumor, there is a great role of medical oncology, and there is evolution of medical oncological protocols for management of testicular tumor. A great part of it will be covered under that heading as such. I'll rush you up through the surgical aspect and primary presentation of testicular tumors. Now, these are extremely interesting tumors that despite their aggressive presentation, their management using various chemotherapy protocol provides us some excellent outcomes. So about 2 in 100 2 cases per 1 lakh population is what we see, and incidence is variable, maybe slowly rising. It usually involves men in their 20s and 30s, early 30s, and 5-year survival, as I've told you, has significantly increased with improvement of various chemotherapy protocols. Apart from protocols, the other cause is improved awareness, availability of hospitals and screening procedures, availability of tumor markers, and understanding in pattern of spread and use of cisplatin based chemotherapy, and aggressive multimodal treatment approach are the underlying reasons why things have improved. Now, when we are talking about testicular tumor, we can, from your pathology knowledge, divide it into germ cell origin, non-germ cell origin. The non-germ cells are Sertoli-Leydig gonadoblastoma, and there can be secondary tumors. Most common are of germ cell origin, which can be seminomatous or non-seminomatous tumors. So germ cell tumors are either seminomatous or non-seminomatous tumors. Non-seminoma is a group of tumors which includes embryonal cell carcinoma, yolk sac tumor, teratomas, choriocarcinomas, and the most common variant, which is mixed variant of all these types of tumors. So in germ cell, I told you there are seminoma and non-seminoma. In non-seminoma, I told you there are 4 or 5 subvariants. In seminomas, there is either a classical variant or an anaplastic variant. A special variant called as metastatic variant also exists. Now, stage to stage, there is no difference in significance, but seminoma usually perform or are easier to manage as compared to their non-seminomatous counterparts. Now we are talking about tumor markers. Now, what are tumor markers? Tumor markers are products that indirectly suggest tumor activity in body. So there are 3 hormones that have been earmarked as markers of testicular tumor, which includes beta HCG, alpha fetoproteins, and LDH. mostly non-seminomatous tumors show activity of tumor markers. If in seminoma most are silent, but if there is any rise, there will be rise in LDH, which is tumor marker of tumor burden, may be raised in 15%. 15% patient may also have rise in beta HCG. Now come to the non-seminomatous tumor. And some variants, embryonal cell carcinoma, poor prognosis, usually affects young. Histologies, what tells us about being embryonal in origin? Alpha fetoprotein is tumor marker of this tumor. Yolk sac variant, good subvariant of non-seminomatous tumor with better prognosis, generally in young. Histologies that give us the marker to it. Teratomas. Now, teratoma is a very special variant whereby two or more germ cell elements are seen. And these tumors are notorious to be extremely chemo and radiosensitive and generally require surgical treatment wherever they are. So that makes it poor prognosis compared to even teratomas of ovary. Undifferentiated teratoma can differentiate after chemotherapy. So teratoma or growing teratoma syndrome is something that is encountered in post chemotherapy patient scenarios. Now mixed germ cell is the most common variant. You see elements of almost all the subvariants with rise in or activity in all the three tumor markers. Pure form is a choriocarcinoma, which is rare but extremely aggressive tumor, has affinity to florid metastasis even to CNS and early hematogenous spread. It's highly chemoresponsive tumors. Now when a patient now let us discuss some clinical aspects of it. So that is what concerns us. If a young male walks into OPD with scrotal swelling, then how to proceed with it? So mostly these patients present with some indirect history suggestive of local trauma or that has brought their attention towards pre-existing enlargement in size of scrotum or the testis. So that at the clinical aspect of it, it's important to palpate and find out about the scrotal sensation, whether it's present or lost, any associated pain or fluctuant swelling with it, so that we can easily differentiate between the benign TDs, which is hydrocele or infected hydrocele, or epididymoorchitis, which is most common differential of any scrotal swelling. After the clinical examination comes the role of imaging, the most important of which is ultrasound, that can help us find out solid or cystic elements and inflammation in epididymis. High frequency probes are usually used. Now the treatment aspect of it. So now so the second after doing your examination and ultrasound, these patients should undergo test tumor marker assessment, and to find out the histopathology, we subject our patients to high inguinal orchidectomies. So high inguinal orchidectomy means that the scrotum is not violated, but an inguinal incision is given. The entire testicular complex is delivered through that, and the testis is the spermatic cords are clamped and testis is removed, and based on the primary pathology, then the lymph node in the landing sites are treated depending upon the variant of it. Now if it's if we are dealing with seminoma with no lymph node burden in retroperitoneum, maybe inguinal orchidectomy alone may be sufficient, or with low dose retroperitoneal irradiation. If we are dealing with high stage, that is retroperitoneal lymph node, then chemotherapy through various protocols are required. The role of RP-LND in seminoma is extremely limited, but in the subvariant, which is non-seminomatous germ cell tumor, there remains a role for retroperitoneal lymph node dissection. Here also the diagnosis made on high inguinal orchidectomy, And following hyoinguinal orchidectomy, the retroperitoneal deposits are treated either with CT or retroperitoneal lymph node dissection, depending upon the tumor markers and the size of the retroperitoneal lymph nodes. So where all surgery is involved? Surgery is involved in hyoinguinal orchidectomy, so that we find the diagnosis and histopathological surveillance of it, and in form of retroperitoneal lymph node dissection, which is usually offered to stage 1 non-seminomatous germ cell tumor, or in higher stage post chemotherapy residual masses, or if there is evidence of teratoma and retroperitoneum. So RPLND thus is offered either pre-chemo or post-chemo residual masses. Post-chemo RPLND is integral part of management in advanced non-seminomatous germ cell tumor and remains a surgical challenge. One of the most challenging surgery is done in and by urologists is post-chemo RPLND. So when can one predict that there will be a residual disease that will require RPLND? If residual mass post chemo is usually more than 2 or say 1.5 centimeter, then these patient requires further evaluation in form of repeat tumor markers, a PET scan, and if there is element of teratoma suspicion in primary tumor, then there is very high chance of residual disease and requirement of post chemo surgery. Now CT abdomen here showing retrocaval, interaortocaval residual extending till the aortic bifurcation. These are dramatic lymph node pictures, and these are pictures of RPLND done by us. Here in this image we are mobilizing things, then incision of the posterior peritoneum medial to inferior mesenteric vein up to DJ flexure, and then ascending colon and cecum is reflected. So this is mobilization and exposure of retroperitoneum. Here IVC is exposed and lymphatic tissue is removed by split and roll technique, and common aisle, and the entire lymph node mask is dissected from aorta to iliac to and IVC. Here you can see split roll and retrocaval dissection, the tumor burden that is retrocaval after lifting IVC in the blue one, and taking care of the lumbar vessels. We talk of templates. So template is a standard term that is used for dissection. Right template, left template, bilateral template, or modified template. These RPLND templates are usually marked by the upper border of renal vessel, the lateral border is marked by the ureter, the lower border is marked by the iliac vessels, and the medial border is usually on left side is the IVC. When you are doing left side RPLND, it's the IVC. When you are doing the right side RPLND, it's usually the medial border of lymph node in the interaortocaval, so anterior border of aorta. This is how a retroperitoneal deposit usually looks like post resection. There are various terms: a right template, a left template, a standard bilateral template, a nerve sparing template, or just a post chemo resection of growing mass. So nerve sparing is something that is desirable because a lot of sympathetic or parasympathetic chains run in this area, and they affect pelvic parasympathetic system, and thereby the erection in usually as these are young males. So nerve sparing is desirable and can be offered to early stage retroperitoneal deposits. Now if there are severe desmoplastic reaction as seen post chemo or seminomatous variant, or there are large mass, then we may require to change our approach to a thoracoabdominal approach, or may have to add removing adjacent organs like adding nephrectomy, splenectomy, or if colon or colonic vessels are involved, hemicolectomy may also be required. If non-resectable structures are involved like SMA, celiac axis or portal, then it becomes a contraindication. Dramatic CT showing a huge mass filling almost half of the abdomen, This was a surgical picture. This is the surgical picture whereby we are showing you after a lot of mobilization how the mass was lifted over the pedicles, and each and every small vessel was ligated. About 20 centimeter of this mass was removed. In this case even kidney was involved, and the kidney was also removed together with mass, and this particular patient has a growing teratoma. So just to show you what histopathological finding at RPLND or residual masses usually show. Post primary chemo, usually it becomes necrosis in 33, teratoma in 33, and very viable tumors in 33%. It was earlier. Now it has, with improved protocols, it is 45, 40 and 15%. But when you give salvage or second line chemotherapy, the chances of having a viable teratoma or tumor increases rather than necrosis or fibrosis. Although standard treatment for marker positive disease is chemotherapy, salvage RPLND has shown to improve the survival in these patients. Overall relapse rate of post chemo surgery RPLND is 27%, good risk ranging from 11 to 45%, and adjunctive RPLND has a complication rate of about 18%. As I told you, it's extremely technically difficult, especially if there is fibrosis and if bleomycin has been used for as a chemotherapy agent. Now testicular carcinoma in situ, which may be seen in 5% of contralateral testes, and 5% of patient will develop testicular tumor on long-term follow-up. So testicular atrophy is associated with higher incidence of CIS, and careful ultrasound to look for microlithiasis is required. So I would rush you through clinical and what surgical terms we basically use for these tumors. Let us now see the other part of it, which is the medical oncology and radiation oncology part, and how they help in treatment of these tumors.
रंजीत मैं स्टार्ट कर रहा हूँ, ठीक। हाँ LT2 मेरा, मैं शुरू कर रहा हूँ, ठीक है ना, राइट, ठीक है सब, थैंक यू। Good afternoon. In the next half an hour, I will just discuss the role of radiotherapy in genitourinary malignancies other than the prostate cancers. Unfortunately, radiation is an area which is not routinely covered in the undergraduate teaching curriculum. So initially, I will be covering little bit about the basics of radiotherapy, and then I will go to the subject in detail. What is radiation? It's a form of energy which propagates through the space or medium. You can see that in any room there are a lot of electromagnetic waves, like the radio waves, visible light, infrared rays, ultraviolet rays, X-rays, gamma rays. They are all different types of radiation. Radiation can be broadly two types. What is the ionizing radiation and non-ionizing radiation? We don't, nobody fears about that non-ionizing radiation. They are safe to us. But the ionizing radiation, it is what we use for radiation as a form of treatment for malignancies. And the routinely what we use is the photons. You might have heard about the photons. There are two different names, X-rays and gamma rays. X-rays, we call it when the accelerated electron bombards with the target tungsten, and then the rays are produced. That's known as X-rays. Gamma rays, it's naturally occurring photons which are produced by the decay of radioactive isotopes like the cobalt 6, cobalt 60. And there are other particulate radiations, particulate accelerated particles that are used in radiotherapy for treatment, like the electrons, the neutrons, the protons, and the heavy ions. So the radiotherapy is a localized form of treatment, but we should say that it has got other systemic effects also. It's usually delivered over 5 to 7 weeks. It's a fractionated sort of treatment. It's specialized treatment, and it doesn't cause any pain when you give radiation. If you think of radiation, there are two types of radiation. One is external beam radiation, and the other is brachytherapy. In the external beam radiation, the source of radiation is outside the body. It's away from the body. There are different types of machines that you use for delivering external beam radiation. In the first picture, you can see the basic telecobalt machine, and the second one you can see the linear accelerator. The third one is a proton therapy machine, then the tomotherapy, then the cyber knife, and the last one is the gamma knife. They are all very costly equipments, costing many crores of rupees. And when it comes to brachytherapy, the source of the radiation is placed either near the patient or inside the tumor. And in the first picture, you can see it is the HDR brachytherapy machine. And how we do it, you can just visualize it. And we initially insert hollow catheters into the area of the tumor. You can see in the other three figures, the hollow catheters are inserted. They are plastic catheters, and the very small radiation source, the iridium 192, it goes through these catheters and stays in that area for a particular period of time, and then comes back. So that is how brachytherapy is delivered to a patient. If you had been to the radiotherapy department, then you might have heard about this many buzzwords like 2D radiotherapy, 3D radiotherapy, IMRT, VMAT. These are all different techniques of radiation. I am not going to go in detail of this technique, but you should know that these are the different techniques that we use for when we plan and deliver radiation. But I think you should know about the IGRT. It's image guided radiotherapy. In this, what we mean is we do an imaging of the patient in the treatment position when the patient is lying on the treatment machine for treatment, and we ensure that the patient is exactly in the right position where the rays are going to hit. That's way of ensuring the accuracy of delivery of radiation. That's known as image guidance. You might be wondering to know that we have a CT machine, CT scan attached to our treatment machine. That means it's part of the treatment machine itself. That we call it as cone beam CT. That is used for image guidance. Then another thing that you should know is the stereotactic body radiotherapy. In this, small targets in the body are targeted accurately with stereotactic accuracy. We target that and ablate that lesion in 1 to 5 fractions. This is known as stereotactic body radiotherapy. And radiation is utilized in almost all genitourinary malignancies. See a prostate, renal cell carcinoma, see urinary bladder, testicular tumors, carcinoma of the penis, and AIIMS tumors. And as you know that we are not going to discuss about prostate today, and I will be going into the detail of each other malignancies. Where do we give radiation? One is, we should know that one is known as radical radiotherapy, or it's also known as definitive radiotherapy. Here the radiation is given as a curative modality. That means that radiation is the main method of treatment. This is known as radical radiotherapy or definitive radiotherapy. Suppose if surgery is the main treatment and we give radiation either before surgery or after surgery, it is known as neoadjuvant or adjuvant. Neoadjuvant we give before surgery, and adjuvant if we give after surgery. And other thing is when the radiation is given as a palliative intent. First, coming to the renal cell carcinoma. Renal cell carcinoma is supposed to be a radio-resistant disease, radio-resistant disease. You should know that there is something known as radio-resistant, radio-sensitive tumors. Here, RCC is supposed to be a radio-resistant tumor. That means we need very high dose to cure the disease. So, in RCC, you don't have much role of radiation. The main use of radiation RCC is in the palliative settings. Previously, radiation was given as a post-op indication in many cases, like the posterior margins, lymph node mets, or perinephric fat invasion. But studies have shown that it's not going to help, rather it's going to be detrimental to the patient when you give post-operative radiotherapy in a case of RCC. Let us see why it happens. You know that after we remove the kidney, what is remaining is the tumor bed. In the tumor bed, the normal intestine and other structures will come and occupy the space. So, if you are going to give radiation to the renal bed, you are going to give a significant radiation dose to the normal structures like the intestine. So you are not able to increase a dose to a big extent. The dose that you can give is maximum 45 to 50 grays. This is what we call in routine. It's very lower dose in radiation oncology. 50 grays in conventional fractions. So that is not going to cure the disease. Rather, it's going to give more of a side effect. So it is not routinely used. When we come to the mechanism of action of radiation, it is basically the damage to the DNA that happens. One is the single strand break and double strand break. That can be either by the direct hit of the radiation to the DNA strands, or it can be by the indirect action by initially what happens is that the water molecule get ionized and these ions get hit the DNA. There can be two mechanisms. One is the direct hit to the DNA or indirect hit also. That is the routine action of radiation that we usually tell by fractional radiation. But when you use high dose radiation like in SBRT, the single fraction high dose radiation, the ablative dose, the mechanism of action is different. You can see in this slide, it is something like a ceramide mediated epithelial apoptosis of the blood vessels in the tumor. So you are able to achieve a better cell kill by using SBRT. And there are other mechanisms of radiation like the immune mechanism. I am not going to the details. So when you are using SBRT, you are making a radio resistant tumor a radio sensitive. That means you are bypassing the routine mechanism and using other mechanisms. So in the renal cell carcinoma, you can use, suppose if there is a tumor in the metastasis to lung or bone or in brain or in liver, and you can ablate these lesions, limited number of metastases. We can ablate these lesions by high dose radiation. This oligometastasis we call for limited number of metastases, usually less than 5 number of metastases, limited number of organs. You can ablate these lesions by using high dose radiation targeted accurately, limiting the dose to surrounding structures by SBRT. This is routinely used in RCCs, metastatic RCCs, limited metastatic RCCs. Other situations are when you have a widespread metastasis, then suppose there is a lung mets causing hemoptysis or cough, then you can give good palliation by giving radiation. You can stop the hemoptysis. And then in bone metastasis, for decreasing the pain or avoiding fracture, you can give radiation. And it's a routine use in spinal cord compression. In spinal cord compression is supposed to be a radiation emergency. So, you have to intervene as soon as possible, preferably less than 24 to 48 hours before the motor deficits or neurological deficit sets in. And if you give radiation early, you will be able to preserve the neurological function in a good number of patients. Other situation is the brain metastasis, where multiple brain mets, patient will have severe headache, vomiting, or other features of increased ICT. This can be a little bit relieved by giving palliative radiation for the brain. The dose that we give is very simple. It can vary from a single fraction to 10 fractions or 15 fractions. Depending on the patient condition, you decide. It can be either 8 grain single fraction to the involved site, or 30 grain 10 fraction, or 45 grain 15 fraction. You can decide according to the situation. This is one of the example of metastasis to the spine from RCC. You can see the very badly destructed vertebra. If you are able to stabilize this by neurosurgical procedures, is well and good. If you are not able to do that, then giving palliative radiation to the spine will help in a big way in decreasing the pain and to improve the stability. Coming to carcinoma of the urinary bladder. As you already heard, urinary bladder is divided into 3 types: superficial bladder cancer, muscle invasive bladder cancer, and metastatic bladder cancer. In superficial bladder cancer, there is no much role of radiation, except in a few cases where you give RT or surgery for a T1 grade 3 sort of tumors. That's not routine also. But radiation is used for a muscle invasive bladder cancers. It can be used as an organ sparing, organ preserving approach. It's equally good as a surgical approach. And other approaches are pre-op and post-op situations. And other one is a palliative radiotherapy for the bladder cancer. What are the indications for radical RT? It's one is as a substitute for surgery and can be used for locally advanced or muscle invasive disease. And there will be some patients who will be medically inoperable because of other comorbidities. In those patients also, it's a good alternative. And it can be used in unresectable disease also. In unresectable disease, what happens is that you expect poor results even with radiation. When we go for as a bladder preserving approach, it is not radiation alone that is given. It's a combined modality approach. You need to do a complete TURBT, transverse resection of the bladder tumor, before taking the patient for a chemoradiation. After a complete removal of the bladder tumor, you plan the patient for radiation and chemotherapy. And chemotherapy is usually given concurrent. That means with radiation, to increase the effect of radiation. We call it radio sensitization. And who is an ideal candidate for bladder preservation approach? It's a unicentric tumor which is less than 5 centimeters, T2 or T3 bladder tumor, without a hydronephrosis, and after a complete TURBT. This is the ideal candidate. And once if you do a chemoradiation approach as a bladder preservation approach, you can expect a 5-year survival of around 50 to 60%. And about 3/4 of the patients will have a maintained bladder in long term. When you go for chemoradiation, there are basically two different approaches that you will be seeing. One is the Massachusetts approach, where after TURBT, you consider the patient for an induction chemoradiation. That means some part of the radiation is given initially. Maybe if you are giving 60 gray, then you give 40 gray initially. That means in 4 to 5 weeks. And then after that, you do a check cystoscopy. Once you see that there is no residual tumor in the bladder, then you go for further radiation and finish the complete course. If there is a residual tumor in the bladder, you send the patient for cystectomy. The other approach is the Erlangen approach, where you deliver the whole course of radiation upfront, radiation chemotherapy upfront. And then in both these approaches, after finishing the chemo radiation, you do check cystoscopy very frequently, once in 3 months or so, and see what the status of the disease. If there is a superficial bladder cancer, you resect it and do intravesical treatment. If it is a muscle invasive disease, you go for salvage cystectomy. That is the routine approach. There are different ways of treating carcinoma bladder, but the basic fundamental issue is that what all structures that you are covering, you are treating when you treat a bladder cancer. The whole bladder with the tumor has to be included. Usually the regional nodes, regional draining nodes are also covered in the radiation portal. If it is a low lying tumor, you have to include the proximal urethra also. And in the conventional 2D approach, you use bony landmarks to design the radiation portals so that you are covering these structures adequately in the radiation field. This can be either a 2-field or a 4-field approach, depending on the anteroposterior separation of the patient. If it is a very thick separation, then you go for a 4-field approach. If it's thin patient, then you go for a 2-field approach. But nowadays, with the use of more and more of advanced imaging in the radiation planning, what we do is we do take the CT scan of the patient 3 mm slice in the treatment position after a proper immobilization, and then we draw the tumor and the surrounding normal structures on the computer. These computers are known as treatment planning systems, and then our radiation physicists do place the beams virtually on this image sets, and then we see how much dose the tumor is getting, how much dose the normal structures are getting, and we ensure that we are covering the tumor properly and sparing the normal structures. And then we have got set guidelines how much dose the tumor should receive, and how much dose the less dose the normal structures should receive. And once we are happy with all these dosimetrics, then we deliver the radiation to the patient. This is the present way of delivering radiation. That means we need to know much of the radiological anatomy when you plan the ablation for radiation. And the dose that you give for bladder sparing approach is anywhere between 64 to 66 Gray in conventional fraction. That means the patient will undergo radiation for 6 to 7 weeks time. You should also know what is known as hypofractionation. By hypofractionation, what we mean is the more dose per fraction. Routinely what we give is 1.8 to 2 Gray per fraction. Here you can give 3 Gray per fraction. So more dose per fraction and limiting the number of fractions. So you are able to finish the treatment in a short period of time. This is more important in this COVID era because more number of patient visits to the hospital, more chance of exposure for the patient to COVID, and more exposure to the hospital staff also. So hypofractionation is more preferred in this COVID era. And something known as hyperfractionation also you should know. That means the patient will be getting more than 1 fractions per day. And I am not going to the details of this dose because in preoperative radiation it may vary from 5 fractions to 25 fractions, and palliative radiation it can be 5 fractions or 10 fractions. Preferably all these patients should be treated on a linear accelerator than a cobalt. Coming to the testicular germ cell tumors, the details of testicular germ cell tumor will be covered by my medical oncology colleague, but still I will just go through the radiation aspects. They are supposed to be very radiosensitive tumors, like they are also chemosensitive, so they are radiosensitive tumors also. And we don't need very high dose for cure of radiation for cure. They just melt away with radiation. But one thing particular I will like to suggest is that these patients are young, so we need to be careful about the fertility issues. We need to counsel the patient properly, and if needed we need to go for sperm banking before starting the radiation. And we do take precautions to shield the testis during the radiation also. When you think of indication of radiation for a germ cell tumor, it's mainly for a seminoma. For non-seminomatous germ cell tumor, there doesn't and non-seminomatous germ cell tumor does not require radiation. There is no role of radiotherapy in non-seminomatous germ cell except in a palliative settings. It's mainly indicated for seminoma. Even for seminoma, it is indicated in stage 1 and stage 2A and stage 2B. Stage 2A and stage 2B, that means till less than 5 centimeter lymph node in the para-aortic region. In stage 1, you will hear that there are, after high inguinal occlusion, there are 3 important approaches. One is single agent carboplatin, or the second one will be active surveillance, or the third one will be radiation. So after in stage 1 seminoma, that means the seminoma is confined to the scrotum. There is no involvement of the para-aortic nodes. So in these patients, they are prone for recurrence in the para-aortic nodes. So if you are not considering the patient for single agent chemotherapy, or the patient you are not comfortable in following the patient up closely, then you can get away with giving a low dose 20 gray in 10 fractions to the para-aortic region. Basically, you are prophylactically irradiating the para-aortic microscopic disease. If you are doing by conventional fractionation, you ensure that you cover the lateral borders, you cover the transverse process of the vertebra on the para-aortic region. This you can see the portals of radiation that you use. In stage 2 seminoma, you already have a disease that has come to the para-aortic region in stage 2A and stage 2B, and here you are supposed to treat after high inguinal occlusion. Radiation is the main treatment, and you give radiation to the para-aortic region and ipsilateral pelvic region. We call it as dog leg field because the shape of the field is like that. You can see in the figure. It's known as dog leg field. Initially in this dog leg field, we give a dose of 20 gray in 10 fraction. That means 2 weeks radiation is given for this field. Then after that, even stage 2A, you give an extra dose to the area of the nodal disease. That we call it as boost radiation. That is 10 gray to this nodal disease. And in stage 2B, you give an extra dose of 16 gray in 8 fraction. That means 8 days more the patient will receive radiation to this grossly enlarged nodes. But with modern radiotherapy planning, what we do is we take a CT scan of the patient, as I already discussed, 3 mm slices. Then on this virtual CT sets, we draw the aorta and inferior vena cava in each and every slice. Then we draw the kidneys, the intestine, and all the normal structures. And then we grow the aorta and IVC by 1.7 to 1.9 centimeters. And this the grown volume is taken as the surrogate for the area to be treated. And this area we fit the MLCs. MLCs mean they are the blocking things that you can see on the linear axillary machine. And then you plan and ensure that the kidney gets the least dose, the area to be treated get the proper dose, and then you deliver the radiation. Coming to carcinoma of the penis, it's an uncommon malignancy. You can see that it accounts for less than 1% of the male cancers. There is a little higher incidence in rural registries like Bashi, and it usually presents in 5th or 6th decade of age. And about 30 to 45% of the patient present with the palpable inguinal nodes, but only half of them will have a disease. About 20 to 40% of the clinically negative inguinal region will have occult metastasis. So in little advanced cases, you need to prophylactically treat the inguinal nodes also. And carcinoma penis is mostly it is managed by surgery. And so in those cases, many of them will need adjuvant radiation after surgery, and it can be taken as a radical treatment in inoperable patients, And in early cases, as an alternative to surgery, you can do radiation as an organ sparing approach, and it's a good modality for advanced metastatic patients, which gives a good palliation. There are both. You can either use external beam radiotherapy alone, or it can be brachytherapy, or it can be combination of both. But anyway, I should remember that the area of interest is the primary tumor area and the primary nodes whenever they are involved or treated prophylactically. In the first figure, you can see that the radiation portals are covering the tumor and the nodal areas, the pelvic nodes and the inguinal nodes. So that is external beam radiation. You usually give a dose of around 60 grays in 60 grays. And the second figure, you can see it's a brachytherapy, where you insert the needles into the tumor and give radiation. It's also a fractional treatment. You can see that you finish the treatment in 15 fractions. That means patient will finish the treatment in 7 to 8 days. This is one of our own publication. You can see the results. Initially, you can see the brachytherapy catheters placed in the tumor area, and then after you finish the radiation, you can see the fourth figure is the follow-up figure. You can see the tumor is not at all seen in that image. It's very effective treatment for early cases, and more importantly, it's an organ sparing approach. Coming to a little bit about the Weems tumor. Radiation is used after surgery to the local site. Whenever there is a metastasis to lung, liver or brain, radiation is also used. One peculiar thing is that when you are giving radiation for Weems tumor, it should be started within 10 days of surgery, and beyond 10 days there is a tumor cell repopulation, and so there will be higher incidence of tumor relapse. If you give too early, there is a little issue with the healing also. So generally around 10 days, we don't go after 10 days. The indications of radiation: for a favorable histology tumor, stage 3 and stage 4; for an anaplastic tumor, from stage 2 to stage 4; and for all cases of clear cell sarcoma and rhabdoid tumor, you give radiation. There are two target volumes that we usually use. One is the flank radiation, and other is whole abdominal radiation. The whole abdominal radiation is used when there is a spillage during surgery, or there is a rupture of the tumor before surgery. Then you give whole abdominal radiation, or else we routinely go with flank radiation. The dose that you use is very less, 10.8 gray in 9 fractions, and even for the metastatic sites, so the dose that you use is less. But one particular thing is that they are small children, so you need to immobilize them properly, or else the patient will move during radiation. And you can see this blue, we call it a blue bag or alpha cradle. So here you make a particular immobilization device for a patient. You have to fit the curvature of the patient so that patient doesn't move within that. Another important thing is that many times you require anesthesia for delivering radiation, or else patient will move during radiation. And this summarizes the radiation for this Weems tumor, and this shows the area we treat when we use flank radiation. Basically, we cover the kidney with margins and the paraortic nodes. And this shows the whole abdominal radiation. Upper border, you can see that we are covering the diaphragm and variable portion of the liver on the right side, and the lower border we keep below the obturator foramen, and we usually shield the other normal kidney and the acetabulum when we give radiation. And this shows the area when we go for lung radiation. And the issue with delivering radiation for this Weems tumor is that they are growing children, though, so late effects of radiation will be profound in them. The growth defects and even the second malignancies are also an issue. Okay, that's all, and let me hand over to Dr. Ranjit to cover about the medical oncology aspects. Dr. Ranjit. हाँ फिर डेस्टिनेशन है ना शायद, मैं यहाँ अपने देखा बता देना अपने जब भेजा भैया बता देना अब यहाँ डालने के बाद देखा।
कैन आई स्टार्ट? उसे ही बस एनलार्ज करना था ना, हाउड है ना?
हाँ स्टार्ट ऑलरेडी।
दिस इज ये गो टू मीट है।
नहीं जस्ट बता दो ऑलरेडी है और जस्ट आप बता दो ना।
हाँ
हाँ फुल करके बता दो और
ओके। am I audible?
वन वे
It is only one way. Okay.
इनफैक्ट मोबाइल में आप देख सकते हैं।
Great. So overall, if you look into all the urological malignancies, it is close to 20% of all the cancers which are found in male and 3% of all the cancers which are in female in India. And these are all the site of cancers which are included in urological malignancies. Now the oncological treatment across all of them, it is rapidly changing, minus the testicular cancer, but apart from it, it is rapidly evolving. And the major paradigm shift is seen in kidney, prostate, and then bladder. In all the urological malignancies, I mean testicular malignancy is one which is highly curable, and we would mainly focus in this talk on kidney cancers, on the testicular cancers, and bladder cancer. So coming to testicular cancer, I mean this accounts for 1% of all the malignancies in the males. It is more common in the young adolescent and young adolescent age group. If you look into the age standardized rate, it is 1.7, and in India it is the 32nd most common malignancy. This is just because the fact that India is a very young country, and the people who are 60 years or more is only 9%. And as you know, the cure rates are very high. And if you only look into age-wise and you concentrate adolescent and young adult as an age group, testicular cancer is one of the most common cancers. So the risk factors is mala or undescended testes, and there it is often bilateral is the risk. Cryptorchidism, the risk is increased by 10 to 40%, and most of it is actually seminoma. Even after repositioning the testes, the risk somewhat remains. If you look into the family history, if a person is affected, the other family members, they have a 4 to 10 times higher the chance. And it also has risk on the contralateral testes. The other risk factors which has got some association is orchitis, trauma to the testes, and receiving ionizing radiation. Interestingly, it has got a very peculiar and characteristic genetic defect which is not found in any other tumors, which is invasion of 12p. That is seen in close to more than 80% of the tumor. At some patients there is duplication of 12p. And as I was discussing, this is the commonest malignancy between 20 to 40 years age group. Clinically, they may present as a testicular swelling or scrotal mass. There is a dragging sensation in the testes. There is pain abdomen or swelling, which is predominantly because of the retroperitoneal involvement. When it goes beyond it, it might produce lung metastasis, which would cause some cough, dyspnea, hemoptysis. And then it might also present with neck swelling, mainly in the supraclavicular region. And the other B symptoms, systemic symptoms of fever and weight loss, it is seen close to 10% of the patients. This is the information of ISCH at AIIMS, and what we see is The median age is closely, I mean, we follow what happened in the West. The incidence of advanced disease and the advanced symptoms, as you see here, it is more as compared to what is seen in the West. The differential diagnosis of a testicular tumor, if a person who presents to you with testicular tumor, and these are the closed differentials: hematoma, hydrocele, varicocele, spermatocele, epididymitis, orchitis. If you do a good clinical examination, all these things can be sorted out. But most of the time you would require a ultrasound of the testes. Now, if you look into the histology, histology is based on the way they present. They are biologically of two groups. The one with the best outcome is seminoma, and it constitutes close to 40% of all the patients, and the rest, all the categories, they are clubbed into non-seminoma. There are some subtle differences, but mostly they have an equivalent outcome as regards to the histology. Seminoma is mostly, it is pure seminoma, and most commonly it is classical seminoma. If you look into all the seminomas, 90% will be classical, and close to 5 or 10% will be some sort of non-classical seminoma. In non-seminoma, the most common type of non-seminoma was found to be malignant teratoma. Now, the predominant difference between a seminoma and non-seminoma is seminoma tends to be pure of a single histology. Non-seminoma, they are more commonly mixed. In 80 to 90% of the cases, they are mixed. There will be more than one histology in the testicular tumor. Now, the investigations are very important in these cases. You do a complete routine, and then you do tumor markers. Now, this is one of those cancers which has got a very nice serum tumor marker. You could, like alpha beta beta HCG and LDH, and they are pretty much consistent with the tumor burden, especially lactate dehydrogenase. And to look for the tumor as the primary, you do a ultrasound of scrotum, you do a CT scan of chest, abdomen and pelvis, you do a brain MRI to rule out CNS metastasis. When there is heavy disease load which is going up till the lungs, there are good number of lung metastasis, or the patient is symptomatic, or the tumor markers are very high. You also do pulmonary function test, because the chemotherapy which is given does contain bleomycin, which is a pulmonary toxic drug. And importantly, because these patients are very young and many of them are not married, you would also like to do a sperm testing, and if they are okay, then go for a sperm banking, because the incidence of infertility in such cases are close to 20 to 30%. Now, if you go into the tumor markers, there are two tumor markers which are very important. One is beta HCG, which has got a half-life of 18 to 36 hours, or AFP, which has got a half-life of 5 days. In seminoma, beta HCG mostly, they are mute. They don't secrete beta HCG, but those patients who have got very heavy disease load, in 10% of such cases, it could be seen. Alpha beta in males, it is a mixed germ cell tumor which might or might not have a seminoma component. It is mostly seen in non-seminomatous germ cell tumor. Even if you found seminoma on the testicular mass as histopathology and your alpha beta protein is raised, they are classified as mixed germ cell tumor. They are not pure seminomas. Now, teratoma, which could be benign or malignant, they are mostly mute. Especially the benign teratomas, they do not secrete anything, beta HCG or alpha beta protein. Embryonal carcinoma, it secretes alpha beta protein. Alpha beta protein amongst the non-seminomatous, it is predominantly secreted by yolk sac. Now, choriocarcinoma, which is seen predominantly in association with gestational GTN, which is in females, it is very, very rare in male patients. It is less than 1%. But whenever it is present, it is a nightmare for the physician, because they are highly aggressive and they are not very much curable. Now, this is the staging system. The staging is pretty simple. Stage 1 is when the tumor is restricted to only the testis. When it involves the regional nodes, that is in the retroperitoneum, it becomes stage 2. When it goes beyond that into the organs like lungs or liver, they are called as stage 3. Now the TNM staging system here, it has got many important characteristics, like there is no stage 4 in lung cancer even though they are metastatic, which is pretty important to remember. Again, the tumor markers are helpful in deciding the stage and ascertaining. Like those patients who have got a very high tumor markers, they are classified into if you look into the stage 3C, even when there is only node and there is no discernible metastasis in organs like lungs or liver, if the tumor markers are very high, they will be classified in stage 3C, which is the maximum stage which could be assigned to a case of germ cell tumor. Now, those patients who have got advanced disease like stage 2 or stage 3, you need to also re-stratify these cases. This re-stratification, it tells you about the prognosis of a patient. Now, if you look into the re-stratification of seminoma, that is here, those patients, in seminoma there is no poor risk. It could be only good risk or intermediate risk. Seminoma, any primary site, the primary sites could be either testis or retroperitoneum, or rarely they may also present in mediastinum, just like Yuvraj Singh. And it is called as good risk when there is no organ metastasis, especially liver, and it is called intermediate risk when it has got organ metastasis, just like in liver or bone. And in non-seminomatous, the site remains very important. When it is mediastinal primary, they are classified as poor risk tumor. Those who have got testicular cancer, or there is no cancer in testis but that is retroperitoneum is presumed to be the primary, then it could be either good risk or intermediate risk. And the further stratifications can be done whether there is any pulmonary or visceral metastasis, or what is the tumor marker status. Now, the treatment is based on the understanding of the disease. It is based on histology and the stage, general condition of the patient, the biochemical parameters. All patients should ideally undergo orchiectomy upfront, followed by further adjuvant treatment. For all the stage 1 germ cell tumors, especially if it is seminoma, the treatment of choice is active surveillance, because many of those patients, they do not have micrometastasis, which could be to the tune of 65 to 75%, and they do not require any extra treatment. The other options are, you could also do because most of the micrometastases are present in the nodal region in the retroperitoneum, we can do a prophylactic paralytic radiation depending on which side it has affected, or you could give a very reduced dose of chemotherapy, which is carboplatin, for a cycle of 2. It has got excellent outcome. The cure rates are close to 100% in such cases. In some studies, it was shown that invasion of retitestis or a presence of LVI is a poor prognostic factor. Now in India, many of these cases, they come after FNSC or biopsy of the testis as stage 1 germ cell tumor. Normally FNSC or biopsy of testis is contraindicated in such cases. You need to see whether it is a tumor, what are the tumor markers, maybe an MRI, and then you go for orchiectomy. You need not do a tissue biopsy before this thing, because these things are pretty classical. However, non-seminoma, which is a little poorer prognosis than seminoma, if it is stage 1, the best option is active surveillance. With you should offer active surveillance to this patient with a pinch of salt. The relapse rates are 20 to 30% higher than what it is seen in seminoma. The easier way is to give them a cycle of chemotherapy, which is standard BEP, and they are cured to the tune of 90 to 95%. These patients can also undergo nose-sparing RPLND. You could see whether there is evidence of micrometastasis. If there is micrometastasis, you need to give some adjuvant chemotherapy. If it is indicated, RPLND itself will suffice. There is no role of radiation here because non-seminomatous germ cell tumor, they are not very radiosensitive. And here as well, the prognostic factors remains presence of LVI, if the histology contains embryonal carcinoma component, or PT3 and PT4 tumors. Now, in non-seminoma, if it is stage 1S, I mean, if say the tumor markers were elevated before doing an osteotomy, you do a CT chest, abdomen, pelvis, there is no evidence of any disease. And after osteotomy, after many half-lives, if the markers are still elevated, even though there is no evidence of disease, they are given 3 cycles of adjuvant BEP. Now, these are the patients where there is micrometastasis which is there, but it could not be detected by your conventional radiology. It remains a very important problem, but at the same time, stage 1S has got a very good outcome. This also underlines the fact that tumor markers in a cancer like germ cell tumor are very sensitive, and it decides how should this patient be managed. So in a stage 1 germ cell tumor, the disease specific survival is almost 100%. Now coming to stage 2, now stage 2 means there is evidence of tumor in your retroperitoneum. Now for the most, it is BEP for 3 cycles. Now if there is some issue of lung function, then a person is an athlete, you should avoid bleomycin in such cases, and you could give them EP, omit bleomycin and give an extra cycle of EP, that is EP for 4 cycles. Now if there is residual disease, it is very difficult when you do all these 3 cycles or 4 cycles of chemo and there is some residual disease which could be anything beyond 1 centimeter in CT scan. Now in seminoma, there are only 2 options. If it is a pure seminoma, there are 2 options. It could be either disease which has not responded, which is very unlikely, or it is fibrosis. Now after fibrosis as well, it might look as a sort of residual tumor in CT scan, but most of the time they are not. So what you do is, you could do a PET CT scan in such cases. Now where there is tumor, it will take glucose and it will shine up in a FDG PET scan, and if it is not shining up on a PET scan, it is negative, and these patients are followed. And if the PET CT scan is positive, now these patients are subjected to RPLND. Now the problem is the timing of doing a PET CT scan in such cases. The PET CT scan, the normal time to become negative, it is still not known, and ideally it becomes positive towards maybe somewhere around 6 or 9 months, but standard guidelines, they suggest that at 3 months you should be taking a decision. But because these patients are still very much curable, even if you see at 3 months when there is disease, you could still wait for some more time, and if the FDG is showing a decrement, these patients are actually having residual disease and not tumor. In non-seminoma, if there is residual disease which is more than a centimeter or 1.5 centimeter, they require surgery in most of the cases, and most of the time it is either teratoma or necrosis or fibrosis. In close to 10 or 20% of cases, there could be active disease which is present, and you need to do some adjuvant chemotherapy in such cases. Now radiotherapy to residual sites in non-seminoma, it is a controversial area. Possibly it is not required as it is seen in seminoma. Now stage 2 patients of germ cell tumor, they are also curable to the tune of 95%. Now stage 3, which is beyond the retroperitoneal location, it is either in the lung or somewhere else. So these patients, they require adjuvant BEP, for 4 cycles. So the chemotherapy is a little more intense here. This is, and the approach remains the same for residual disease post chemotherapy. Anything which is more than a centimeter for non-seminal matters, they should require surgery. Now bleomycin, worldwide it is given 30 international units in day 1, day 8, day 15. This is actually an European protocol. Etoposide is given for 5 days at the dose of 100 mg per meter square. Cisplatin is 20 mg per meter square, day 1 to day 5. Now at our institution we also follow an institution protocol of giving a reduced dose of bleomycin, because 360 units of bleomycin could be toxic to the lungs, as we have seen in our cases. So we give a lower dose of bleomycin, and in our experience, which we are yet to publish, these two protocols, they are almost similar. There is no difference in outcome in whatever the protocol we have used. Now the common toxicity to chemotherapy is, it is mainly hematological and GI toxicity. Hematological, it is anemia, neutropenia or thrombocytopenia. Thrombocytopenia is not very common. Nausea, vomiting could be very a topical problem in such cases, and they require a lot of care. Pulmonary toxicity, it is predominantly driven by bleomycin in such cases. Metabolic syndrome in long-term follow-ups could be a problem in such cases. It could be because of the platinum, which is, the cisplatin and other chemotherapy as well. Hearing loss is a complication of cisplatin. Infertility, the incidence of infertility, which is mainly due to chemotherapy, it is not that great. It is 5% or less. These patients, by the virtue of this disease, they may become infertile. Even at diagnosis, many of these patients are actually infertile. Some few cases, close to 1%, they might be detected as of evolution of infertility, in very rarely. The other regimens which could be used for relapsed germ cell tumor once they relapse after BEP is VIP, VEIP, TIP. None is better than the other. Now these are few pictures of bleomycin toxicity. You could see there are interstitial changes in the lung page in the first picture, and in the second picture you could see the skin toxicities, which is predominantly seen at the back. Now this is the outcome of testicular cancer worldwide and our own information. Those patients who are seminoma, good risk, our survival is a little less than what it is reported in the international data, and the good risk patient, the survival is close to 80%, which should have been 90%. The patient who are intermediate risk, the survival is close to 50 to 60% in our hand. In non-seminal germ cell tumor, those with poor risk, the outcome is 40%, which is same as the international data. The good and intermediate, they are almost the same as international data, that is 90% and 80%. Now let's come to kidney cancer. Now the cell of origin is from the epithelium of the renal tubules, and the incidence is 15 to 22 per 100,000 patients per year. It is 2% of all the malignant tumors. In India, the age-adjusted rate is less than what is reported in the West. It is close to 1 in males and it is 0.5 in females. Now Indians who are living in the Western countries, they have higher incidence, which suggests the influence of environment. It is more common in male patients with a ratio of 2:1. The age peak is close to, the median age is close to 50 years. Now the most important risk factor in kidney cancer is smoking, followed by obesity, hypertension, those patients who are on chronic hemodialysis, ionizing radiation, occupational exposure to cadmium, trichloroethylene, those patients, those people who are working in, those who are oven workers, and also the analgesic abuse associated nephropathy, they are also at higher risk of developing kidney cancer, which is mainly in the renal pelvis. It also has a familial connection. Some hereditary syndromes are associated with higher chances of RCC. The most important is VHL. Now in patients of VHL, it is mainly clear cell carcinoma. There are other sort of tumors like hemangioblastomas, which could be in CNS, some other tumors like neuroendocrine tumors. Then hereditary papillary RCC is also there. Papillary, these are the histological subtypes of RCC with a hereditary connection. Now the clinical presentation, the classic triad of hematuria, flank pain and palpable abdominal mass, it is seen in close to 10%. There are actually no early symptoms. In the West, close to 2/3 of patients, they are incidentally detected when they are evaluated for something else. And this is an internist tumor. It can present with anything. It has got a lot of paraneoplastic syndrome. They might present with fever, thrombocytosis, raised DSR. Some patient, they might present with erythrocytosis. It might present with hypertension. It might present with hypercalcemia. It might present with this Stoffer syndrome where there is hepatic dysfunction. In the workup, it is a complete routine plus urine. There is a CT scan of chest and abdomen, pelvis, and a CT brain is required only if it is clinically indicated. Most of the time, if it is a localized tumor, or even if it is advanced, it doesn't require a biopsy to prove that it is an RCC, it is a malignant problem, because radiologically it is pretty much characteristic. But at some time, when it is advanced and it doesn't require a nephrectomy, there you could subject these patients for a percutaneous biopsy either from the metastatic sites or from the primary. The differentials are renal cyst. Angiomyolipoma is an important differential, which is a benign tumor, and when they bleed, they could actually be confused, but the clinical presentation is completely different. Nephroblastoma, it is a youngest tumor. At times it could be a sarcoma. Now 30% of the cases in the West, they present with distant metastasis at the diagnosis. The tumor which are 3 cm or less, they hardly present with metastasis, but yes, there are some rare examples. Most common site of hematogenous metastasis is lung, followed by liver, bone and CNS. The nodal supply metastasis is predominantly to the pelvic and the paraaortic lymph nodes. And this is the tumor staging of 7th edition. This is mainly helpful in the early stage cancers, where you could offer them a partial nephrectomy and organ sparing approach. But for those patients who have an advanced disease, it is mostly, you could classify them as easily as localized, locally advanced and metastatic. For localized, it is clearly surgery, which could be a radical or an organ sparing partial nephrectomy. For locally advanced as well, surgery is the treatment choice. And for metastatic, surgery could be performed in some amount of cases, but it is mainly systemic treatment. This is the staging. Those patients who are 7 cm or less, they are classified as stage 1. Stage 2 is anything which is 7 cm or more. Stage 3 is locally advanced, involving the vena cava or thrombus, and stage 4 is distant metastasis. Now, more than 95% of RCC, they are derived from tubular cells, and almost 3/4 of them are clear cell type. The other sites are, the other type is papillary, which is from the PCT. The chromophobe collecting duct and miscellaneous histology is close to 10%. Now, in cases where it is advanced or metastatic RCC, you could use very simpler variables to classify them, whether it is a good risk patient or an intermediate risk or a poor risk patient, just based on your hemoglobin, calcium, neutrophil count, platelet count. When the neutrophil count or platelet count, these tumors, they could be producing a lot of inflammation. If there is signs of inflammations like low hemoglobin, higher neutrophil count, higher platelet count, that would reflect in the performance status, this patient's general condition, if the general condition is not that good. And these patients, when they diagnosed as metastasis at the first presentation, they are poorer cases to deal with. Now, as I was discussing, for early disease, it is either radical nephrectomy or a partial nephrectomy. And for locally advanced disease, it is still surgery is the mainstay. The adjuvant treatment in locally advanced disease, it is still a debatable issue. There is some evidence of giving some systemic treatment which might reduce the micrometastatic rate, but it is still not very clear whether that sort of treatment, like a TKI called as sunitinib, it can be given as an adjuvant treatment, but the exact benefit of an adjuvant treatment is curability of these cases. As we understand, these drugs, they do not cure such cases. So the adjuvant treatment as of today, it is debatable. Now metastatic disease, now in advanced clear cell RCC, there are all sort of treatment like immunotherapy, nivolumab and ipilimumab, mainly in the patients who are intermediate or high risk. For good risk patients, it still remains as VEGF TKIs, sunitinib, pazopanib. But as we are talking in 2020, the treatment is now using both this VEGF TKIs with immunotherapy. The advanced non-clear cell RCC, TKIs are preferred, and they mostly, I mean, the guidelines are pretty poor here. The management, it essentially resembles for clear cell RCC. Now the role of cytoreductive nephrectomy in metastatic RCC should only be restricted to those patients who have got local problem, a bleeding primary. Otherwise, the role of cytoreductive nephrectomy is also debatable in such cases. Those patients, they might not require, a good number of cases where they are mainly symptomatic from the metastatic sites, they might not require a cytoreductive nephrectomy. In cytoreductive nephrectomy, you are only removing the kidneys, maybe some lymph nodes, but it still remains, I mean, it is a debatable thing that whether you require excision of primary in presence of other metastases which may not be removed and controlled with systemic therapy. Now the side effects of targeted therapy, I mean, normally we give VEGF targeted therapy here. Now the tumor, after some time, they require angiogenesis to grow and to produce metastasis to other organs. Now if you inhibit the angiogenesis, then this tumor may not grow. That is the principle behind this VEGF targeted therapies. Now here you are not addressing the tumor directly, you are indirectly hitting them by inhibiting their blood supply. Now when angiogenesis is inhibited, because there are a lot of normal activities, they are dependent on angiogenesis, so the side effects could be troublesome. So even though we call it as targeted therapy, it should work on the tumor, it is not so. It work on other things. Like it might result with fatigue, diarrhea, hypertension. There is something called as hand-foot syndrome. It might result in alopecia, pruritus, hypothyroidism. So it has got a lot of side effects. These side effects are different than what is seen in cytotoxic therapies. Now adverse effects of immunotherapy is it produces, I mean, what it does is it licenses your lymphocytes which are not very much active, and these lymphocytes, they become very active and they attack the tumors thinking that they are foreign, and they reduces the tumor burden. So that is immunotherapy. But at the same time, it also causes a lot of immune related adverse events. Almost every organ is affected, just like in your connective tissue disorders. There will be a skin rash, some diarrhea, asthenia, and there is involvement of lung, like interstitial lung disease. There are a lot of autoimmune endocrinopathies, be it hypothyroidism or hyperthyroidism, at times addisonian or pituitary dysfunctions. But cytopenias, I mean autoimmune cytopenias, are very, very rare. Now let's come to cancer of urinary bladder quickly. We just got another 8 minutes left. The most common risk factor is cigarette smoking. It could also be due to chronic bladder irritation, and when there is exposure of polycyclic aromatic hydrocarbons in some occupations, drugs like cyclophosphamide, and some infections like cystosomia. But cystosomia infection, it mostly relates to squamous cell carcinoma. The rest of it, they are mainly associated with transitional cell carcinoma. Now, most common is a painless hematuria in close to 75% of the patient. There could be irritative or obstructive symptoms in 25% of patients. There could be pelvic pain in those patients who have locally advanced disease. Poor appetite or weight loss, it signifies advanced or metastatic disease. The investigations are pretty standard. You do a routine and urine, you do a chest x-ray. Most of the times they are localized problems. You would require a cystoscopy under anesthesia and TUR. You would require a MRI or CT of abdomen and pelvis, and other metastatic sites if the patient is clinically symptomatic. Now this is the TNM staging. I am, in the interest of time, I am skipping it. Now the early stage treatment, I think it had already been covered by my urology colleague. Now let's come to muscle invasive bladder cancer. Now muscle invasive, once the muscles are involved in the bladder tumor, they are never localized. A good amount of them, they are actually metastatic disease. So when you know that even though the metastasis is not clinically or radiologically discernible, these patients have micrometastasis to the tune of 60 to 70%. So the current standard is do a neoadjuvant chemotherapy followed by radical cystectomy. Even though you know there is a tumor, after doing a complete TURBT, you would subject these patients for neoadjuvant chemo. After 2 or 3 months, these patients are subjected to radical surgery. The regimens which are used are cisplatin based regimens. It is either MVAC or gemcitabine cisplatin. Now bladder can also be preserved because these tumors, they are restricted to the bladder, and they are pretty much chemosensitive as well as radiosensitive. But nevertheless, if you convince a patient for a bladder preservation, there are many patients who are willing to preserve their bladder and they are not comfortable with without a bladder. They are the patients where you could approach for a combined modality approach. You need to do a complete TURBT followed by chemotherapy and radiation in such cases. Now the problem is, even when you do a combined therapy in such cases, close to 20% or 30%, depending on their presentation, they might still require a surgery as a salvage after CTIT. So at our institution, we only do concurrent chemoradiation in a well selected cohort. Those who are not willing, those who are not willing to undergo radical surgery, early tumors, only they are subjected to chemotherapy and radiotherapy. Now management of metastatic disease, they are very chemosensitive tumors, but because of the location of the tumor, there is a lot of kidney dysfunctions which are either pretty apparent or subclinical. So you need to see what is the creatinine clearance in such cases. Platinum are very important drugs. Cisplatin is the drug of choice with combination to other drugs. Now cisplatin eligibility in such cases are very important. Should a patient is eligible for platinum administration, they are taken for cisplatin based combination. Those who are not cisplatin eligible, they are given either another congener like carboplatin, which is a less nephrotoxic platinum, or these patients could be given immunotherapy. Now that is my last slide. I will be happy to answer a few questions if you could. कोई क्वेश्चन आंसर नहीं है?
Have you
नहीं एक का चलेगा सर बस